Good evening, everyone, and welcome to today's session. And I hope you're all studying well. And today is 24th, another 10 days to go before the game. Kittu, Meenu, and many more who are all online, please drop a line in the WhatsApp study groups that the live class has started. So let's make the great beginning, doctor. A 30-year-old man underwent laparotomy 2 months back. Good to see Ashwin Maran, Attar, and many more who are all online. He noticed that he has got a scar which is itchy, painful. It is limited to the original scar area. That is the most important identifying factor here. So that qualifies to be hypertrophic scar is what you have to remember. Very good. Khaja, Muhyiddin and many more. Keep punching your answers, comments, and let's make it more interactive, doctor. Right? Now, quickly, doctor, this question is definitely going to come in the tomorrow's NEETPG exam. Be very sure about. Preetham, Merry Christmas. Santa Claus bana diya, or I don't prefer to. So, good. Merry Christmas. Yes. So, hypertrophic scar versus keloid. ये तो श्योर शॉट आने वाला क्वेश्चन है, कुछ भी डाउट नहीं है. Hypertrophic scar develops soon after the surgery. It improves with time. It remains within the confines of the wound. Very important. And it occurs when scar crosses the joints or the skin creases at right angle. That is important reason for hypertrophic scar. And it improves with appropriate surgery. It's more frequent, and it is not that it is more common in blacks or anything. Whereas keloids, more in the blacks, they are more rarer, obviously. Blacks are rarer in India. They are worsened. If you try to operate on keloid, it will worsen by surgery. It is typically earlobes, shoulders, sternal notch, and rarely across joints. Whereas hypertrophic scar is across the joints. Important difference between the two. It will spread outside the boundaries. Keloid will walk out. Keloid will walk out of the area of injury. And it will not improve with time. It will take months after the trauma to develop. The keloid is what you should remember. Now, doctor, what is this ECG pattern which is being shown in a patient of dyspnea? The moment they say dyspnea, ECG, even without looking ECG, it is pulmonary embolism. Lead 1 में after the R wave there is a S wave. इसको कहते हैं S1. Q3 lead 3 में before the R wave there is a negative deflection which is called, this is the R, doctor. Negative wave before R is Q. Negative wave after R is called S. So Q3. Similarly, the T wave is showing inversion. So S1, Q3, T3 is the classical feature of the pulmonary embolism is what you need to remember. A 55-year-old female with rheumatoid vasculitis is on steroid therapy, and now she has developed the hip pain. So what you are able to classically see in this case is the development of a vascular necrosis. One of the risk factors is taking steroids, sickle cell disease, gaucher, etc., etc. Good to see Nagreddy Saab, Preetham, and many more who are all online. Please drop a line in your WhatsApp study groups that the live class has started in the Facebook, Telegram, WhatsApp, wherever you are there, right? And call our friends to join. So my promise to all of you was December 1st to January 4th. Every day we will have a grand test. By evening 8 p.m. we will upload the test, and you solve the paper, and next day we discuss the questions. So every day after you have invested 3.5 hours of your time in solving the paper, just like the NEETPG, and then taking 1 to 1.5 hours of discussion, you should decide what are those 10 topics where I'm going wrong in every day and improve. That is the only thing that will do a magic for you when it comes to the scores tomorrow. Let me be very sure about it, doctor. So, these are the features of a condition where you are able to see this in the otoscopy. In the otoscopy, you are able to classically see this. So, it is otosclerosis. Tympanosclerosis is what you are able to see, otoscopic appearance. So there is a blue foot plate, and that is an important sign of the tympanosclerosis. Now what is the ECG pattern which is being shown in the figure? Where do we see this? Is a very, very important question. So typically these are the classical findings, ECG findings in case of hypokalemia. GI loss, hypothermia, total parenteral nutrition, they are all the predisposing factors for hypokalemia. But beta blockers lead to hyperkalemia. Hyperkalemia. That is what you need to remember. Okay, doc? So, a prominent U wave, T wave के बाद एक U wave आता है. This is the normal line. There is a depressed ST segment and there is a biphasic T wave. T wave के बाद और एक positive wave आता है. U wave is not necessarily a negative wave. Letter U looks like negative, but U wave होता है positive or it can be negative, but it is happening after T wave. After T wave. That's what you need to remember. So that is a classical feature where the ST segment become depressed. Now, the ultrasound is showing you in the figure what type of twinning pattern. Mark as my word. Twins is the favorite topic of the examiner, doctor. You can't escape it. This is called twin peak sign, which is classically seen with dichorionic, diamniotic. It is also called lambda sign, is the other name which is being given to it, which is typically indicative of dichorionicity, is what you need to remember. Now, what is this clinical condition which is being shown in the figure? Most likely because of fungal keratitis is what you need to remember. Classical appearance. A dry texture, satellite finger-like lesions, and an immune ring is the classical feature which you see in the case of the fungal keratitis is what you need to basically remember. Now the lesion which is being shown in the figure, what is that called as? It is an ulcerated sebaceous cyst. Ulcerated sebaceous cyst is indicative of Koch's peculiar tumor is what you need to remember. Now with regard to this orthopedic gadget which is being shown to you, which is used to fix the carpal bone, this gadget. What is this? It is the Hubbard screw. It provides the compression against the fracture site. It is used to fix the intra-articular fracture fragments. It has got a differential pitch mechanism. They're all the true statements which you need to remember. Very good. Keep punching your answers, doctor. That is how the live session can be made to become livelier, so that you are feeling one-to-one with everybody else and also with the teacher. So that is the beautiness. So once upon a time it used to be face-to-face classes, crowded classrooms. They're all going to be obsolete. Now the teacher can sit anywhere. Himalayas mein bhi baith ke padhai de sakte. Students also can go for a honeymoon to Shimla or Nainital and can attend a live broadcasted session interactively. So that is a beauty part. So please don't forget to tell your juniors, doctor, to enroll to our online mbbs.com video library. We have 2 lakh PowerPoint slides like this, 3,000 video lectures covering 1,000 plus hours of video lecture, covering 953 topics with 30,000 MCQs which are being revised. In addition to this, we also have nearly around 200 full-scale grant tests along with the discussion like what we are discussing now are made available. Additionally, we also deliver 500 hours of live content across the year, every day, a couple of hours. Every Saturday, subject test with discussion, Sunday, grant test with discussion. So, you have everything available. It is all up to you to make the best use of both the free live session and the subscribed video library. So, the best place for preparation for NEETPG, I can be able to vouch for you, and I know very well with about 2 lakh medical students being mentored in the last 20 years, I know very well what are your uncertainties, what are your little shortcomings, and where are the learning gaps for most of the students. We know that formula, and there is no secret formula. There are 953 topics. You have to spend at least 400 hours of your time. Whatever be your past, you will still become a winner. So that is the promise I give to all of you. Now, doctor, what is this ocular condition which is being shown in the figure? So, typically pseudoxerontoxin, shield ulceration, Trantus spots, they're all the features of the vernal keratoconjunctivitis is what you need to remember. Whereas, all lines are a feature in case of trachoma. There will be a conjunctival scarring in trachoma, which is basically called All's line, is what you have to emphatically remember. Now the ECG is being shown to you, and looking at this ECG, what you are able to classically see. So you are able to see peaked T waves, right? Peaked T waves, which is an important clue. So that is hyperkalemia. Now the examiner is asking, hyperkalemia is the important side effect of trimethoprim, is what you have to emphatically remember. That's good. Shabu's World rightly says peaked T wave of trimethoprim as a side effect with is what you're able to see. Now, what is associated with hypothyroidism? All of you know, Hashimoto thyroiditis leads to hypothyroidism, autoimmune. It can be associated with myasthenia gravis. So type 1 diabetes, Edison, celiac disease, uh, then pernicious anemia, myasthenia gravis, SLE, rheumatoid arthritis. They're all the associated features that you can see in Hashimoto, which is associated with hypothyroidism, is what you need to remember. In carcinoid syndrome, the part of the heart most commonly affected. So all of you know that right atrium to right ventricle, tricuspid valve, that is the most common location for the carcinoid to metastasize through the systemic circulation, through the venous return. Typically, it reaches the right side of the heart, is what you need to remember. A 40-year-old lady with pheochromocytoma, most characteristic is always a paroxysmal hypertension. You may find all the other, but most common is the emphasis there. This is a beautiful question, doctor. Stimulant of the growth hormone release. Actually, accept name. It is not accept. Which is a stimulant of the growth hormone release? Come on. Punch your answer, doctor. Out of the 4 things shown to you, which is the stimulant of growth hormone? Simple question, but exam mein this type of questions will be rate limiting, seat limiting MCQs. Akshaya proposes hypoglycemia. Monish, clean bolt with bromocriptine. Jagadishwari, Jindabad. So, hypoglycemia. Doctor, it is the NREM sleep, not REM. NREM sleep, slow wave sleep, during which the growth hormone typically is produced. So what are the agents you use to treat growth hormone excess? Somatostatin and the analogues of somatostatin. Octreotide, lanreotide, vapreotide, sandostatin. Similarly, dopamine receptor agonists like bromocriptine is also an inhibitor of the growth hormone. And growth hormone antagonist, pegvisomant. What is that? मेरे साथ और एक बार बोलो, एक पेग ले लो. Pegvisomant is the growth hormone antagonist, is what you need to basically remember. So what are the indications for the bromocriptine? One is acromegaly, second is Parkinson. अब सबको मालूम है ना डॉक्टर? So what stimulates the growth hormone secretion? What inhibits the growth hormone secretion? One of the favorite question of the examiner, doctor, if you have done this question wrong, high time that you go back to onlinembbs.com video library to do the revision. We had an extensive discussion on this topic. So decrease blood glucose, decrease free fatty acids. When you are starving, when there is a trauma, stress, excitement, exercise, NREM stage 3 and 4, growth hormone releasing hormone, they all stimulate the growth hormone production. Whereas increased blood glucose, obesity, cortisol, increased free fatty acids, they all inhibit the growth hormone production, is what you need to remember. What is under anterior pituitary control, doctor? Anterior pituitary is producing all your LH, FSH, TSH. So gonad function is dependent. Subdural hemorrhage is venous bleed. Extradural hemorrhage is arterial bleed. So it is the cortical bridging veins which typically lead to the subdural hemorrhage. When the lateral part of the medulla, lateral medullary syndrome of Wellenberg, What are the things involved? Vagus is involved, nucleus ambiguous is involved. So dysphagia, nystagmus, ipsilateral horners, because from the hypothalamus your sympathetic tract while descending down through the brainstem will pass to the lateral medulla. So ipsilateral horners, they're all the true statements which you need to remember. Now doctor, dissociative sensory loss मतलब क्या होता है? Your pain and temperature is carried by lateral spinothalamic tract. It is will be passing very close to the central canal. So any dilatation of central canal will compress it and loss of pain and temperature will be there. But your dorsal columns which are passing posteriorly, your dorsal columns, typically the dorsal columns are not affected. So vibration position, they are all not affected. Only pain and temperature is affected when there is a syringomyelia with central canal expansion is what you need to remember. Goods syndrome क्या होता है? Thymoma with hypogammaglobulinemia is called as Goods. Thymoma can precede or it can occur after the immunodeficiency is what you need to remember. Now what is the most common site of hypertensive hemorrhage, doctor? If you take the last 20 years of NEETPG, All India PG medical entrance, every entrance में question आता है, like a standard question, right? हाइपरटेंसिव हेमरेज होता है बेसल गैंग्लिया में, भैया यहाँ होता है बेसल गैंग्लिया, ये है बेसल गैंग्लिया एरिया is what you need to remember. So one very interesting question. Thalamus, आप सबको मालूम है ना, thalamus and basal ganglia. How do you know that this is a ganglionic bleed? Ganglionic bleed, but not thalamic bleed. So typically thalamus means, you remember, this is the shape of the T, no doctor, you will write like this, T. Horizontally oblong hota hai thalamic bleed, vertically oblong hota hai ganglionic bleed. That is how you can be able to remember. Right, doctor? Now, Lafora bodies, where do we see them? We see them in the juvenile progressive myoclonic epilepsy is what you should remember. Juvenile progressive myoclonic epilepsy में Lafora bodies. So these are the Lafora bodies, doctor. Lafora. Let me tell you one thing. One of the bodies, favorite question भैया, Luvi body, Lafora body, Negri body, you have to be very sure. One more thing I am telling you, today only, immediately you have to go to the onlineMBBS.com video library and do the revision. Inclusion bodies. You should know what are cytoplasmic inclusion bodies, what are intranuclear inclusion bodies, which are Cowdery type A, Cowdery type B. Abba, I feel banging the head if I remember this topic. Still, entrance के लिए पढ़ना पड़ेगा, right? Very good to see. Kalai Rasi, very good. Kalai Rasi, you are from which part of Tamil Nadu, doctor? And what is your dream branch? वो बताना है आप. You have to tell what is the dream branch and which part of the Tamil Nadu are you from? Now, doctor, these are the classical example of Lafora bodies. So, what is the characteristic of the Lafora body disease? Patient will have generalized tonic-clonic seizures, myoclonus, ataxia, dementia, and polyspike and wave discharges on EEG. is what you need to remember. Sir, please help us to find ECG question discussion on online MBBS video library. Very good. Kalai Rasi from Chennai. And on the eve of this Christmas, let us pray that he joins to become. Surgery to kaatne ki kaam hai. Surgery is about cutting. Pediatrics is like taking care of the babies with a soft lullaby. No? There are two opposite sides. Still good. Glad to know that you love both of them. Preetham is asking, sir, please help us find the ECG discussion online mbbs.com video library. Oh, doctor. Online mbbs.com mein 3000 video lectures, 1000 plus hours of content. It's like you should be very sure about discovering where is where, what is where. Very simple, doctor. In the online MBBS Shabu is saying, sir, you are awesome. I wish I had met you earlier. Oh my God. Recently, one of my junior, we guys used to have a good crush on her, but never dared to propose. We met at a conference. So, while laughing, on a cool note, we said, hey, those days we used to have a lot of crush on you, but we could not dare to propose. She said, oh, is it? We would have met much earlier, right? I would have taken a chance. But still, I will ask a permission of my son and can come for a date. So, this sounds like that. So, doctor, let's look into this. NEETPG MCQ practice बोल के एक महासागर रहता है doctor. It is the full encyclopedia. Everything will be there in this. So once you go to this NEETPG MCQ practice, Shabu's world is saying, sir, how do we complete 3000 videos? Don't complete 3000 videos. We are unemployed MD general medicine. There is no other work. Every day 2 hours, discuss video, throw it on the online MBBS. Discuss live like this and push it on the online mbbs.com. Be selective. There is a 953 topic list. Just go to that and be selective. See, doctor, here you have anatomy, physiology, biochemistry. Oh, it will keep on going like Draupadi's Vastrapaharanam. So, you will come to medicine. You will come to the area which is called medicine. Right? In the medicine, if you go to general medicine, this is ENT, this is preventive medicine, this is physiology. Right? This is pathology. Then, this is forensic medicine, okay? Biochemistry. So, you can even go to the general search and can go to, you see, preview. Here you have medicine, no doctor. In that you have here AI PG medicine cardiology. If you go now, here you have the full list of the videos. You have the full preview. So here you have the full list of videos. Now you know where to discover them. So you have all Atma of Dr. Murli Bharadwaj will be heaving over there. बच्चों ECG पढ़ो 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 हमने बहुत दिल लगा के पढ़ाया पूरा ECG में आपको expert बना दिया. There are about 8 lectures. Also you have that associated PPT that you can be able to do a revision. Okay, doc? So that is how is the story of online mbbs.com. Now, doctor, basophilic cytoplasmic inclusion bodies. in the brain, liver, skin, they are found in lephora. What is the most common cause of the carcinomatosis? Meningitis, doctor. Carcinoma breast. Typically, meningitis may carcinoma dissemination occur in 5% of all primaries. Very common is breast cancer. Breast cancer, lung, prostate, lymphoma, leukemia, melanoma, GI tract malignancies, they all have tendency to go to meninges. So this is how a carcinomatous meningitis imagologically looks like. Hey, Commander, good evening. Good to see Commandant today evening. What is the most recent interesting case that you have seen, Commandant? Sabko batao, from Armed Forces Medical College. So dysphagia for fluids but not for solids. Where do we see, doc? Typically in the neuromuscular dysphagia, like a chalasia, we see dysphagia for fluids but not for solids. Triple A syndrome, what are the three A's? Lacrimia, Edison, achalasia. These three are called triple A syndrome is what you need to remember. Very good. Commandant has seen neurofibromatosis. Excellent. Type 1 or type 2? Have you seen the bilateral acoustic neuromas in the patient? What was the presentation? So, Dr. Plummer-Vinson syndrome. You find esophageal webs, it can be pre-malignant, it is leading to dysphagia. But it is seen in female. Typically a patient of Plummer-Vinson is female, is what you need to remember. So, fatafat batao, what type of anemia? Iron deficiency anemia in Plummer-Vinson syndrome. Angular stomatitis, glossitis, koilonychia, pallor, these are the classical associated features. Yeah, these are the associated features. Similarly, there can be splenomegaly, loss of teeth because of the esophageal reflux, enlarged nodular thyroid gland, echlorohydria, post-cricoid web also can be there in case of Plummer-Vinson's syndrome is what you need to remember. Very good. Please upload into our WhatsApp group after taking a due consent of the patient. Yeah. So sideropenic dysphagia. So this is called sideropenic dysphagia. And these are the typical koilonychia, spoon-shaped, glossitis in the tongue. And you are also able to see the post-cricoid web in this patient. And how do you treat that? Balloon dilatation need to be done is what you need to remember. So what are the risk factors for developing the Plummer-Vinson, doctor? Age 40 to 70. Women are at a great risk is what you need to remember. Now, doctor, endoscopic mucosal resection of the Barrett's. It can lead to development of a stricture of esophagus as a complication. Duodenal ulcer, what are the indications for surgery? Any acute perforation, pyloric stenosis, massive hemorrhage, but simply the size and the number of ulcers is not a indicating factor is what you should remember. What are the most common type of type 1 gastric ulcer? Very important MCQ. Come on, let me see how many of you correctly answered. Question number 68. Punch your answer, doctor. Lavanya. What is your answer, Lavanya? Lavanya says C. Vaidya says cardia. Dekha? देखा, एग्जामिनर का फेवरेट टॉपिक मैं बोल रहा हूं आपको, गैस्ट्रिक बॉडी. फर्स्ट ऑफ ऑल, who is that fellow who classified peptic ulcer, doctor? Because of his classification, we need to even mug that classification. Modified Johnson's classification. So what is modified Johnson's classification? Type 1 is ulcer along lesser curvature of stomach. Ulcer along lesser curvature of the stomach. Type 2 is two ulcers are present, one gastric, one duodenal. Type 3 is pre-pyloric ulcer. Type 4 is proximal gastroesophageal ulcer. And type 5 is the one associated with the chronic NSAID usage. And it can occur anywhere, is what you need to remember. So doctor, it is the typical gastric body. Now, malabsorption syndrome. Oh, very good. You have seen hypertrophic pulmonary osteoarthropathy. Super, super, super. So, doctor, malabsorption syndrome, where does it happen? Any parasitic infestation, small bowel diverticulae, post-gastrectomy, not a colonic pathology or a colonic resection does not lead. Fibroblast block is mediated by injury to endothelium. अभी आ गया favorite question. Causes of left axis deviation, causes of right axis deviation. You have to be 100% sure. So left anterior hemiblock, inferior wall MI, right pneumothorax, they all lead to left axis deviation. Left axis deviation. Kalai Rasi is saying, sir, I'm attending your lectures since 1 week only. I'm preparing for 2 months only because of internship. Whether will I get the seat this year, sir? It all depends on, it is multifactorial success. Common sense is most important thing, Kalai, please remember. Common sense, confidence, only two things that make you to win the entrance exam. Confidence truly comes if you have invested 300 to 400 hours of your time on the focused preparation. That is important. Knowing what topics to read. In each topic, what are 10 to 20 points to learn? If you have that focus, 300-400 hours is enough. But who knows, in MBBS 4.5 years, you must have had a better, already had that knowledge built inside. So with that positive spirit, go to the exam and come back with a great news. That is what. So, doctor, let us talk about axis deviation. Whether right axis or left axis, doctor, simple rule. Normally, how is the electrical activity vector is passing? It starts at a A node, goes to a V node, and then what is happening? The ventricle is thicker on the left side than the right side. So predominantly it is contributing to the electrical depolarization. Hence the axis is directed down and towards left. Suppose if the right ventricle hypertrophied, instead of the axis towards left, it will go towards right. So right ventricular hypertrophy, anterolateral MI will cause infarction of the left ventricle. So that is the reason it is not contributing to depolarization anymore. So that is the reason electrical activity is shifted towards left. Whereas inferior wall MI, In inferior wall MI, inferior wall is mainly contributed by the right ventricle. So that is the reason the right ventricle after MI in inferior wall MI is no more contributing to the electrical activity. So the electrical activity is more polarized towards left side. That's what you need to remember. So inferior wall MI, left ventricular hypertrophy, ventricular tachycardia, left anterior hemiblock lead to left axis deviation, whereas left posterior hemiblock lead to right axis deviation. But one of the most important point you need to remember about left axis deviation. You will remember easily, no? Left ventricular hypertrophy, left bundle branch block. Once more, why left bundle branch block lead to left axis deviation? No confusion. Normally, from the AV node, what happens? There is a left bundle, then there is a right bundle. Got it? So, if the left bundle is blocked, what will happen? The right bundle has to do its job of depolarizing the right side. In addition, what else it has to do? The same right bundle has to also go to the left and contribute and lead to the depolarization of the left side also. That is the reason the whole activity from the right, it is migrating towards left, because in the left bundle branch block, it is the right bundle, after finishing the right job, need to even do the left job, so the entire electrical activity is directed towards the left side. So that is the reason left bundle branch block lead to left axis deviation, right bundle branch block lead to right axis deviation. Very important, primum ASD lead to left axis, secondum ASD lead to right axis deviation. Once more, why? Once there is any primum ASD, typically, once more, that will deviate the electrical activity direction towards left side. Anatomically, the primum defect will make the electrical fibers activity polarized towards the left side. So primum ASD lead to left axis deviation, secondum ASD lead to right axis deviation is what you need to remember. So how will you remember it in exam? Primum, secondum. Primum is leading to left axis deviation, secondum is leading to right axis deviation. Right? So PQRS, after P you get S. LMNOPQR, after L only you get R. So P matched with L, S matched with R. So secondum will lead to right axis, primum ASD lead to left axis. Don't tell Murali Bharatwaj will teach like this, but somewhere you need to remember. Similarly, left anterior fascicular block leading to left axis deviation. How will you explain that? Very simple, doctor. First of all, you should know what is meant by fascicles. So once more, typically, if you look at the left bundle, right bundle. Left bundle in turn will divide into one left anterior and left posterior. Left posterior is more towards septum, left anterior is more towards the left ventricle wall. So if the left anterior fascicle got blocked, who has to depolarize the left ventricle wall? It is the posterior fascicle need to finish its job of depolarizing the septum, and also it should go and depolarize the left ventricle. So whole activity is getting polarized towards left side. So that is the reason left axis deviation is seen in left anterior fascicular block, whereas left posterior fascicular block lead to right axis deviation. How will you remember it? Very simple. Anterior fascicle, posterior fascicle. There is only a story about what? Two things only, no? Anterior fascicle, posterior fascicle. Once more, left axis, right axis deviation. So after A comes the P, posterior. After left comes the right. So anterior fascicular block lead to left axis deviation. Posterior fascicular block lead to right axis deviation. Don't tell Dr. Murli Bharadwaj teach like this. Right? Someday to remember. Because in exam there are so many things. So finally, doctor, once more tell me along with me. ASD primum, what does it lead to? Left axis deviation. ASD secundum, what does it lead to? Right axis deviation. Bodia. Then, left anterior fascicular block lead to left axis deviation. Left posterior fascicular block lead to right axis deviation. Khatam. You are sure now? You'll remember it. So tomorrow's entrance, once more, same question, ditto aayega. You have to remember, right? Yesterday only we discussed. Lead 1 looking up, lead 2 and 3 looking down, they left each other, that is left axis deviation. Lead 1 looking down, lead 3 and lead 2 looking up, they are right towards each other, that is right axis deviation. Now quickly tell me, left anterior hemi block, left bundle branch block, hyperkalemia, primum ASD. WPW is a stupid fellow. It can lead to both. It can lead to both LAD, RAD. LAD, RAD. Both the things are possible with Wolff-Parkinson-White. Then right axis deviation. Right ventricular hypertrophy, left posterior hemi block, chronic lung disease leading to COPD, leading to pulmonary hypertension, leading to right ventricular hypertrophy, leads to right axis deviation. You'll remember, right? Pulmonary embolism, obviously pulmonary embolism lead to pulmonary hypertension. Pulmonary hypertension will put strain on right ventricle. So that lead to right axis deviation. Then ostium secundum is right axis deviation. Very important to remember. Normal in infant, right axis deviation can be normal in infant. When you are a kid, no, your right heart is as dominant as left. So less than 1 year, right axis deviation, don't worry, it is normal. Finding tall, lanky people may, like Marfan, you may find right axis deviation. Obese people, left axis deviation. How will you remember? Marfan. R is there, no doctor, right axis deviation. Marfan, tall people. So obese is horizontally tall. So that lead to left axis deviation. That is what you can be able to remember. Now doctor, mitral regurgitation, atrial fibrillation, but the heart rate is decreased, only 60. What is the most likely cause? It is one of the presentation of digitalis toxicity. In atrial fibrillation, we give digitalis for what purpose? In atrial fibrillation, we want to control the ventricular rate. So digitalis is vagomimetic. It blocks the AV node and decreases the ventricular rate. So that is the reason digitalis toxicity presents with atrial arrhythmias, sinus bradycardia, AV block, ventricular arrhythmias. That's right. Ilaya Perumal rightly says for the rate control. Then one more thing, don't forget, yellow-green vision, photophobia, halos, simple nausea, vomiting, anorexia can be there in digoxin toxicity. For the PSVT, what is the treatment, doctor? Adenosine. Wellen syndrome. Who is going to give me the correct answer is going to get the seat. Come on. Shoot you, doctor. Shapal Gyawali is saying, hello sir, I am from Nepal doing internship. I have 4 months left in internship. Can I have the 953 topics that you said in earlier video? I joined WhatsApp group. No worries. Shafal Gyawali, please call our helpline. There'll be, or WhatsApp. If you are in Nepal, you can WhatsApp or call. I give a WhatsApp call 9000868 They'll be more than happy to give you the PDF of the 953 topics. And if you have joined, if you subscribe to onlinembbs.com video library, you have all these 953 topics, PowerPoint, video, and a quiz. They are all available in each of these 953 lessons. You can happily do a revision. Right now. So please take an opportunity. Don't worry about the price. You will get at most affordable price, whatever that you can pay. Very good. Pravalika is proposing unstable angina. Maran is saying Congenital. Nagaraj clean bowl. Pavan Kumar clean bowl. I'll be happy when you are clean bowl. It is typically seen in unstable. Unstable angina's other name is pre-infarction angina. That means you are ready for getting heart attack. So doctor, what is Wellens syndrome? Wellens syndrome is a pattern of inverted biphasic T wave. Inverted T wave or biphasic T wave. Especially V2 to V4. In the patients who have a ischemic chest pain, and it is highly specific for the critical stenosis of the LAD, left anterior descending coronary artery. It is also called widow's artery. What is it called? Widow's artery. Now, they are at extremely high risk of extensive anteroval MI within the next 2 to 3 weeks. And ECG will show this. By the time you rush the patient to take the ECG, he may become pain-free. He may have a normal cardiac enzymes. That is the reason it is typically seen in unstable angina. In Wellens syndrome, there are two types, type 1, type 2 Wellen. Type 1 Wellen may T waves are deeply symmetrically inverted. So suppose if it got inverted like this, or if it got inverted like this, like this. Suppose T wave has two limbs. One is short, other is long, or one is long and other is short. That's called asymmetric inversion. But deep symmetric inversion is called type 1. Type 2 means they are biphasic. The initial deflection is positive and the terminal deflection will be negative for the T wave. Is what you need to basically remember. Now doctor, how is the T wave here? Deeply inverted, right? Deeply inverted. Then how is the T wave here? T wave here is biphasic, initially positive, then became deeply inverted. This is called type 2. Sir, missed call nahi jata Nepal se. You can do WhatsApp. You can drop a line on the WhatsApp, doctor, and our helpline will immediately respond. Right? Don't worry. Now, type 1. So what you are seeing here? You are seeing a deeply inverted Deeply inverted. Can you see that, doc? I'll change the pen color. Pen color. Yes. Now you can see deeply inverted T wave. This is type 1 Belen. So V2 to V3 and V4 to V6 is the common location. Got it? Now, doctor. To decrease serum triglycerides, what do you give? Fibrates. So what is the algorithm for the treatment of hypertriglyceridemia, doctor? High dose statin, if the LDL is also elevated. Fibric acid derivatives, niacin, omega-3 PUFAs for the hypertriglyceridemia. Triglyceridemia is different from cholesterolemia. If cholesterol is also elevated, then high dose statin also need to be given. These are all Jones criteria. Jones criteria except what? Minor criteria except Korea. So you should remember, what are the major criteria, doctor? Jones. Joints, heart, nodule, erythema, marginatum, Sydenham's Korea. They are the major. Previous piece, Jones piece. Previous rheumatic fever, ECG showing PR prolongation, arthralgia, CRPS are elevated temperature, they are all considered to be the minor criteria. Destruction of the valves is a feature of acute infective endocrinitis. Restrictive cardiomyopathy. What are the causes, doctor? Carcinoid, donorubicin, amyloidosis. Mainly amyloid and sarcoid, doctor. They are the main causes which you need to remember. Right? Amyloid, sarcoid. Then scleroderma, idiopathic hemochromatosis, post-radiation fibrosis, metastatic tumors, and inborn errors of metabolism, the causes of sarcoidosis, restrictive cardiomyopathy, which you need to remember. So carcinoid, metastatic tumor, radiation, anthracyclines, busulfan, serotonin, ergotamine, mercury, Loeffler syndrome, endomyocardial fibrosis, they are all the causes which are endomyocardial causes of restrictive heart disease. You should also remember hemochromatosis, Fabry's, Hurler, Gaucher, sarcoid, amyloid. They are the various causes in myocardial. Positive dipstick for the RBC, you find it in rhabdomyolysis, in Wegener's granulomatosis. What type of glomerulonephritis, doc? Focal necrotizing glomerulonephritis. So what is Wegener called? Pauci-immune crescentic glomerulonephritis. Typically in the Bowman's capsule you have parietal epithelial cell and visceral epithelial cell. Parietal epithelial cell proliferation pathologically it is called crescent. A crescent is composed of what, doctor? Proliferative parietal epithelial cells. So in Wegener, you find crescentic glomerulonephritis along with circulating ANCA. It is called pauci-immune crescentic glomerulonephritis. Wegener is a small vessel vasculitis is what you need to remember. So this is how focal necrotizing crescentic glomerulonephritis. That is how you describe the Wegener. Good pasture syndrome. What is it characterized, doctor? There are autoantibodies against the basement membrane. That is the reason there is a development of necrotizing, hemorrhagic, interstitial pneumonitis. मैं 200% कॉन्फिडेंस से आपको बता रहा हूं डॉक्टर, vasculitis. Vasculitis is a sure short topic in tomorrow's NEETPG exam, doctor. Be very sure. So this is how typically we see hemorrhagic pneumonitis. Hemorrhagic pneumonitis, alveolar hemorrhage is a classical feature of good posture. Which type of glomerulonephritis you don't treat with prednisolone? You don't treat post-streptococcal glomerulonephritis with prednisolone. Come on, doctor. You do it for minimal chain disease, lipoid nephrosis, congenital nephrotic syndrome. In all those scenarios, you use the prednisolone. Average head circumference at birth, 35 centimeters. To look at the chronic malnutrition, you need to consider weight for the age. Dandy-Walker syndrome, what do you see? We see cystic expansion of fourth ventricle, cerebellum become hypoplastic. They also have a hydrocephalus. Arnold-Chiari malformations, Dandy-Walker malformation. Arnold-Chiari type 1, Arnold-Chiari type 2. अपड़ा क्या? ये wrong करे तो जरूर पढ़ना चाहिए because it is one of the very high yield area. Go back to the onlinemmbbs.com video library and do a revision. So doctor, this is the normal brain. ये है cerebellum, this is the brain stem, this is the midbrain, this is the pons, this is the medulla. Whatever, beautiful, beautiful. But here what happened? Here there is a cystic dilatation. There is also a hydrocephalus and the cerebellum got compressed. This much a big cerebellum, this got completely compressed. That is Dandy-Walker. So the corpus callosum may be absent or abnormal. There is a cyst, there is an enlargement of the fourth ventricle, and there is an abnormally thinned out cerebellum, and even the brainstem, this is pons, this is the midbrain, this is pons, this is medulla. Even this can become compressed because of this cystic dilatation. In the case of the Dandy-Walker is what you need to remember. So, agenesis of the cerebellar vermis, cystic dilatation of fourth ventricle, enlarged posterior fossa with the upward displacement of tentorium and the upward rotation of the partially developed vermis. That is the combination. Cholestatic jaundice in the newborn is because of neonatal hepatitis. Once more, favorite question of the examiner. Physiological jaundice, milk, breastfed jaundice, breast milk jaundice. All these things you have to be good doctor. How many more days? 10 days or more. Tension लगता है. Tension कुछ भी नहीं है मियाँ. जाना पढ़ाई करो. So hold your breath. So neonatal hepatitis is the favorite topic of the examiner. So you should be very sure extrahepatic biliary obstruction, neonatal hepatitis differences, everything you should be sure, doctor. Ischemic encephalopathy, hypoxic, what do you get? Seizures happening spells decreased level of consciousness. Not increase the tone, decrease the tone. Hypotonia is what you come across. So what is the classification of? That's right, Maran rightly counting. बहुत अच्छा पढ़ रहे मारन तुम. 11 days बोले तो 11 days बराबर याद है ना? No problem. Right? Enjoy doctor, enjoy. Go with only two things. C for common sense. C is confidence, right? एक CC में जाओ, 3000 CC में जाओ and win the exam and come. So doctor, when you call mild, hyperalert, irritable, normal muscular tone and reflexes, no seizures, normal EEG, mild. Stage 2 means hypoxic ischemic encephalopathy. Stages you should be sure. Lethargy, hypotonia, weak suckling, moro will be there. EEG will be showing changes. Severe stage 3 means coma, absent muscle tone, and reflex, persistent seizures, that is stage 3. Radiologically, if you look at this hypoxic ischemic encephalopathy, doctor, this is how typically the appearance is what you need to remember. Nagarity is saying, sir, आपको trust करके मैं आगे बढ़ रहा हूँ. Definitely, doctor. Trust begins where the reason ends. Reasoning मत करो. Exam hall में don't look at the stars and think ये है या B है या B है या C है. Exam hall में reflexly attack. Where is my question on absent seizures? There. Tuck. Where is my question on sensory receptors, pequeñan corpuscles? Tuck. Like that you should approach. You should be very sure what is the game plan of the examiner. Then you are the winner, doctor. Right? Female newborn presents with vaginal bleeding 4 days after the birth. What is the reason? Wait and what do you want to do? Wait and watch is important because it is due to hormonal withdrawal, which is a killed vaccine, doc. Hepatitis A is a subunit vaccine. Direct blood spot test in neonate. Little नन्हे मुन्ने प्यारे बच्चे को एक टो से एक ब्लड ड्रॉप ले लेता. That is called dried blood spot test. There is an easy way of collecting, shipping, storing blood sample. Newborns are screened for inherited metabolic disorders with this dried blood spots. Even for early infant HIV diagnosis also you can use the dried blood spot. About spinal injuries. Cervical spine is more prone to dislocation than fracture. And overall, if you take why cervical spine is more often affected in the trauma, because it is most mobile part of the entire spinal column. That's the reason. Saturday night palsy is an example of neurotmesis, garden spade deformity. Who is going to give me the correct answer? Fatafat type karo, doctor. Fatafat type karo. Yes, doctor. Garden spade deformity. Who is going to give me the correct answer? Oh, you have given missed call. Okay, maybe it is 9:15 p.m. our helpline. Yeah, doctor. I'll tell you. I'll give you one more number, doctor. Please, 9100039974. Okay? 9100039974. Right? Just to drop your line on this number, doctor, and they will तुरंत आपको PDF मिल जाएगा. Right? No worries. हाँ, check करेंगे. Anand Mohan is saying Smith fracture, Nagredi clean bowl, Maran clean bowl. Right? Smith fracture, doctor, not Choffer. See, garden spade deformity. There is a fracture and there is a displacement. So, Smith is also called reverse Colles fracture. There is a volar angulated fracture of the distal radius and it looks like a garden spade. Can you get me? Is it looking like a garden? May we use the spade? No, doctor. Spade. Right? So, it is looking like a garden spade. That is Smith fracture. Whereas dinner fork deformity is Colles fracture. This is opposite to that. This part is, radius is low and that broken fragment is looking up. There, that will look down and the radius will look up if it is paired. So Colles fracture is from the outstretched hand, fall on the outstretched hand. Fall on outstretched hand, foosh. Examiner commonly will give you the history, foosh. There is a transverse fracture of the distal radius with a dorsal displacement, angulation of the distal fragment, right? They also have an associated ulnar styloid fracture in Colles. No, doctor. Sprengel deformity is seen in congenital scoliosis, diasteatomylia, Klippel field. So the scapula, instead of descending down like this scapula, it remained highly positioned up. So you can see this is a scapula placed up. This is normal. So normal caudal migration of the scapula is interrupted. That leads to elevation and medial rotation of the scapula. A 35-year-old lady with chronic backache, she has a collapse of the D12. D12 is same as T12, no confusion. Dorsal thoracic. Our anatomy professor used to call thoracic vertebrae and our radiology professor started calling dorsal vertebrae. Ha, too much now. So, intervertebral disc is maintained. So, what is the differential diagnosis of the TB spine? TB spine involves intervertebral disc. Because how is a vertebra developed? Upper half of the lower vertebra, lower half of the upper vertebra together have a common embryological origin. So when hematogenously TB spreads, it involves even the intervertebral disc. Whereas osteoporosis, metastasis, multiple myeloma, those things do not involve the intervertebral disc. That is the differential diagnosis. Very good? So, what type of TB is most common, doctor? If you have done this question wrong, let me once more tell you, please go back, doctor, online, mbbs.com, video library, and do the revision. Very important topic. Paradiscal is the most common pattern. There is a narrowing of the disc space, there is a destruction of the subchondral bone, and herniation of the disc. So you can remember sadder spine, SC sclerosis, A abscess, disc space reduction, destruction, erosion of vertebra, rarefaction of the vertebral body, rarefaction. These are all the features of TB is what you need to remember. Now doctor, when the water enters the eyes, the blurring of the vision, why does it happen? Because it eliminates the refraction through the cornea. That's the reason. Anisokinia. The retinal image is having a discrepancy in the size. So it is treated with contact lens is what you need to remember. Ropey discharge from the eye. Where do you see? Spring cataract. In vernal keratoconjunctivitis, itching, ropey discharge, frequent blinking, they are all the features. Hypopyon, what does it contain? Fungal filaments it contains. Metamorphosia, Gulliver, Lilliput, small, looks big. Where do you see? In case of posterior uveitis. What is uveal tract? What is uveal tract? Iris, ciliary body, choroid. Choroid is closely abutting the retina. Any choroiditis inflammation will lead to effect on retina and that lead to metamorphosia. Iris is called anterior uvea. Choroid is posterior uvea. That's what you need to remember. What is the shape of X-laws in nulliparous cervix, doctor? Circular. Ovulation is associated with L-head surge. Most commonly, umbilical cord may there are two arteries, one vein. If there is a single umbilical artery, it is abnormal. At what gestational age placenta will take over the progesterone production? Before placenta takes over, who produces progesterone, doctor? Corpus luteum. What is corpus luteum? After the ovulation and the ovum got released, then the leftover part is corpus luteum. That is the one which produces the progesterone until the placenta takes over. So when does it happen? It occurs at 6 to 8 weeks is what you should remember. Let me tell you, doctor, gynecology, obstetrics, no brainer. For that matter, surgical subjects are all, you can leave the brain in the home and go to the exam hall, right? If you are thinking about an answer in gynops means, oh my God, baby will die, right? So, gynops is like gladiator movie. Entered, took out the sword, cut. You don't need to carry brain, right? So, utna sure shot rehta. Occipitofrontal is what length? Biparatal diameter is what length? At what physical time you will see the heart sounds? All single liners, gynops. Gynops also, if you say I am thinking means, you are Einstein, not for NEETPG. Now doctor, urinary pregnancy test detects HCG. Congenital malformation that can be diagnosed in the first trimester would be anencephaly. Residual cast expelled per vaginum is a feature suggestive of missed abortion. Now we are going to have a little discussion. What is the discussion about? Threatened abortion, inevitable abortion, incomplete abortion, complete abortion, septic abortion. Bhajan karo, Ram, Ram, Ram. You have to be sure, doctor. Last moment is all super focus, super duper focus. Definitely आने वाली चीजों को ही पढ़ना है, कुछ भी नहीं, right? So, doctor, mainly you have to look at cervical os. You have to look whether there is any passage of fetal tissue in the clinical vignette given to you. Threatened abortion, how does it present? Abdominal pain or bleeding in the first 20 weeks. Any abortion is first 20. Inevitable abortion also abdominal pain or bleeding. It will be there in all of them. But cervical os, it is closed in threatened. Inevitable may it is open. Incomplete may it is open. Complete also it is closed. Threatened, complete. Threatened, complete, closed. Threatened, complete, closed. Right? Now, passage of the fetal tissue is, you don't see it in threatened or inevitable. But incomplete, yes. Complete passage and uterus is contracted. But incomplete means you pass, but some products of conception are still remaining in the uterus. You call it as incomplete is what you need to remember. Once more, doctor. Typically, threatened abortion, inevitable abortion, there is no passage of content, only incomplete, complete it is there. Threatened, cervical os is closed, inevitable, it is open. Once more, complete abortion, it is closed, and incomplete, it is open. And on ultrasound, there is a live baby still there in threatened. You are only threatened. Dead baby in inevitable. Incomplete, retained parts of the baby. Complete abortion, no baby. Missed abortion means, even missed abortion also, cervical os is closed. But there is no passage of contents. That is the reason it got missed. And there is a dead baby. That's what you need to basically remember. Right, doc? Lavpreet Singh says, Obstetrics gynecology, most exhausted department in medical college. When I used to be in housemanship, no, oh my God, I used to compete with all PGs. We used to have one Dr. Nandini, who was our senior. What, Murli, you already scrubbed over the gloves and waiting. What do you want to do? You want to do hysterectomy? What he used to say. Very nice senior. Please give a little chance, ma'am. At least let me hold a little surgical instrument. So I still remember while assisting her to do the hysterectomy, I still remember that our nurse, Mary, she hit on my back and said, patted on the back and said, "What, doctor? Don't swoop yourself forward. You will get a backache for nothing. If you have done something and got backache, that is okay, but not you have assisted surgery and got backache." A 19-year-old guy in internship. So passionately we used to be part of the labor room. I still remember, but never wanted to be an obstetrician, right? And reading the Datta and Shah, my God, nightmare. Only when I have to teach students for entrance exam, then it was inevitable. Then I started slowly liking the gynecology and obstetrics, reading the gynecology and obstetrics, right? A lot of numericals, very standard questions, standard protocols. You have to be 100% sure with the clarity. Convolute uterus, you see it in case of abruptio placentae. Somewhere I have a premonition in the mind that examiner NEETPG में एक image based question convolute uterus देगा. Now doctor, difference between placental abruption, placenta previa. Favorite question of the examiner. You have to be 100% sure. Premature separation of the placenta is called abruptio, whereas placenta is abnormally placed nearer to the cervical os, that is placenta previa. So what predisposes to abruptio, sudden separation, hypertension, cocaine, trauma, multiparity? What lead to placenta previa for the placenta to come and just implant in abnormal location? Prior cesarean, multiple gestation, twins, multiple induced abortions, advanced maternal age, they are all the predisposing for previa. Previa is painless. Placental abruptio is painful. How will you remember it? Simple, no, doctor. Prematurely something is separating the placenta. Oh my God, it is painful. If you remember that, abruptio is painful because it is, you are tearing out, forcefully separating it prematurely, painful. Then you will remember placenta previa is painless, bright red vaginal bleeding. Then abruptio, see, this is the uterus and you have the placenta, somewhere there is a separation. So this blood has no chance of coming out. So vaginal bleeding is not always present. But in previa there is a bright red vaginal bleeding is what you should remember. Obviously if you separated something from the uterus, no, uterus will go into significant contractions. In fact, any contracting muscle is painful. Painful, uterine contraction, vaginal bleeding not always present, concealed hemorrhage, placenta abruptio. So how do you diagnose? If you can't see blood, you should suspect the blood. You should be Sherlock Holmes. So it is more a clinical suspicion. Ultrasound also poorly sensitive. But in abruptio placenta, typically the products DIC, laboratory shows consumptive coagulopathy. Whereas placenta previa, transvaginal ultrasound can be able to show you that abnormally implanted placenta nearer to the cervical os is what you have to basically remember. Very good. Gagan Kuber rightly says, Covalent uterus can't be diagnosed on ultrasound, only on exploration, absolutely. And in placenta previa, it is very close to the cervical arch, so don't try to put your fingers, your speculum and try to explore, that can precipitate hemorrhage. That is very, very important. So, constant pain, concealed hemorrhage, presence of shock and anemia, hypertension, proteinuria is predisposing, uterus is contracted and hard, fetal parts difficult to feel, that is epilepsy. Painless bleeding, bleeding is severe, shock and anemia, no hypertension or proteinuria, uterus is still soft, it is not tender, and presenting part is high because of the malpresentation. They are the features of placenta previa, is what you need to remember. Oh, your number is 1 minute, doctor. This is a Nepal number, doctor. Nepal number, right? Okay. 98435. 1 minute, doctor. Let me note down. 435. I have a presbyopia to read this. 53642. 53642. 98435 53642. Take care, doctor. I will be very sure, 1 minute, to tell our people to help you. 9843 553642. नागरेड्डी साहब आपके पास वो PDF है तो जरा भिजाओ ना. Please send to Shapal. Nagreddy is one of our very good companion, always in a cheerful mood. Please push that PDF on the to our friend Shapal Gayavli. Now, doctor, least common presentation, the twins. What is that, doc? Both being transverse. Both the Ram or Lakshman, transverse is least common. Gestational diabetes, what is the effect of it? It can lead to macrosomia, hypoglycemia, perinatal mortality, not congenital malformations with gestational. With diabetes, before pregnancy only, if there is diabetes, then congenital malformations are common, is what you need to remember. Now, doctor, what is the most common vaginal infection in pregnancy? Candidiasis, obviously. Triradiate pelvis. Where do you see, doc? In case of rickets and osteomalacia. What are the Kung Fu Panda movements during the normal labor? D. Fire. Engagement, internal rotation, delivery of the head, restitution, external rotation, is what you need to remember. What is the most common cause of the breech presentation? Prematurity. Classical seizure, lower segment seizure. What are the advantages? Lower segment seizure may less blood loss, less chance of gutter, minimal wound hematoma, they are all true. Now, normal physiology in puerperium, there is a retention of urine, constipation, they are all the normal puerperal findings. IUGR babies on delivery are called intrauterine growth retardation, growth retarded babies. Then for cholera in pregnancy, azithromycin is very, very safe. Menstruation may how much blood loss, doctor? 20 to 40 ml. 30 ml is called small size peg. Right? If 2 OCPs are missed on day 17 to 18 of the cycle, what do you want to advise? Very important. You have to say there is a great chance of failure, so use the backup contraceptive. So you should know the protocol, doctor. It's a very common thing in the OPD, whether you are a general medicine guy or an obstetrician or a gynecologist or anybody. Doctor, I missed 2 or more pills. You tell, seek advice from healthcare professional, and that is an indication. But if they missed only 1 pill and it is day 1 to 9 and had sex in the 7 days before forgetting, then also they need to seek the advice of the doctor. Suppose they did not have sex in the 7 days before forgetting, then what to do? Or if it is day 10 to 17, take the missed pill, continue with the pack as usual, use a barrier contraception for the next 9 days. If it is day 18 to 24, start immediately with the next pack. Use the barrier contraception for the next 9 days. And if it is day 25 to 28, take the missed pill, continue with packet as usual, and no additional contraception needed. So doctor, typically, if the person has missed 2 pills, that is an indication for starting alternative method of contraception. Alternative safe pregnancy method. Now, which is not an adverse effect of dipomedroxyprogesterone acetate. It can very much be used during lactation, right? But one problem with that is it can lead to slight glucose intolerance, pelvic inflammatory disease, because progesterone will make the cervical secretions become thicker. It can lead to the perpetuation of the infection. It can lead to bone loss. They are all true. Maximum success of reversal, कहाँ होता है? clip लगाओ, clip निकालो. Most common complication of the dermoid cyst is what, doctor? Torsion. What is the option for the CIN3? CIN3. Srikanth is asking, sir, please don't tell the answers early. मेरे प्यारे श्रीकांत, every day 8 p.m. one new grand test is uploaded into onlinemmbbs.com video library. Kindly subscribe to the onlinemmbbs.com, take the test and join the discussion, right? So I can run fast. Already if you have solved this question paper, this is all available as a question paper online. From December 1st to January 4th every year, we conduct 34 grand tests. That is our promise to you, right? So that's the reason. Please take the test and join the discussion. Maza aata hai. Okay? No worries. And after this discussion is over, we will upload this video, this PowerPoint, everything into the onlinemmbbs.com video library. Under the test you have it. So you can only go through the PPT, listen the video, or take the test, anything you can do. So, doctor, CIN3, hysterectomy, leads, conization, they're all the options. So, doctor, CIN2, CIN3, what are the treatment options? You will do the excision or ablation. LEEP means loop electrosurgical excision. Leads means large loop excision of the transformation zone. You can also do cone biopsy, laser ablation, cryotherapy, but cryotherapy never be used for CIN3, not for CIN3 is what you need to remember. So what are the excision procedures? LEEP, needle conization, laser conization, cold knife conization, hysterectomy. What are ablative methods? Laser vaporization, cryotherapy, cold coagulation, electrocautery. So if it is a CIN1, you can do local ablative or a destructive procedure. CIN2, local excisional procedure. CIN3, hysterectomy plus or minus vaginal cuff. These are the options which are available. Then one word about cryotherapy. So what is the criteria for you to do cryotherapy, doctor? If there is a CIN1 which has persisted for 2 years or CIN2, you have to do cryotherapy. Similarly, Any lesion of ectocervix, or if there is a negative ectocervical sampling, if it is a small lesion, there is no endocervical gland involvement, they are the criteria to do cryotherapy. What is the effective temperature to do that? -20 to -30 degrees. Ice ball of 5 millimeter from the edge of the probe is effective. That's what you need to remember. Now, what are the risk factors for the carcinoma cervix, doctor? Early sexual life, multiple children, multiple sexual partners, they are all the risk factors. Most common carcinoma endometrium is endometrioid adenocarcinoma is what you should remember. Now, this is how typically endometrioid adenocarcinoma histology looks like. Come on doctor, let me check. Kitna padai kar rahe aap? Rokitansky protuberance. Which ovarian tumor do you see? Come on, let me see. श्रीकांत पल्ला, बताओ. अभी आपके लिए मैं रुक गया. राइट आंसर देना है पल्ला जी. वारे वाह, श्रीकांत is proposing teratoma. Sri Lakshmi also. लक्ष्मी जी रोज आइए, रोज आइए. रोज हम 1.5 hour डिस्कशन करते हैं टेस्ट पेपर को. And also subscribe to our online grant test and take an opportunity to take the test, very worth in the last 10 days left over. So our helpline is 9000868356. Also tell your friends, and you also subscribe to the onlinembbs.com YouTube channel, and also request our helpline to include you into the WhatsApp study group, so that the moment I start the test discussion, you will get a notification that the discussion started. Very good. Only Asper is clean bold. Nagreddy sir, आप ये बोल रहे? No, Nagreddy. Jagadishwari, clean bold. Mature teratoma, Srikant, Sri Lakshmi, Jindabad. Rokitansky nodule. There is a raised protuberance projecting into the cyst cavity. Most of the hair arises from this protuberance. That is what you see in case of teratoma. So this part, doctor, this part is the Rokitansky's protuberance from which all the hair is arising, is what you need to remember. So teratoma is usually multiloculated. The cyst contents are greasy, they contain keratin sebum hair. They tend to be a well-defined nipple-like structure covered with the hair, which is called Rokitansky's protuberance. Now, what are the risk factors for the molar gestation, doctor? Typically, any faulty nutrition, Oriental countries, decreased maternal immune mechanism, they are all implicated. So age, extremes of age, less than 15, more than 40. Prior hydatidform mole or prior spontaneous abortion. Vitamin A deficiency, and if the people are outside North America. Now, what is the most common cause of the pyometra, pus in the uterine cavity? So, endometritis is the most common cause. Finally, are there, doctor? End of the today's discussion. Strawberry vagina. Where do you see? Strawberry. All those punctated hemorrhagic spots which you are seeing, doctor, that is the strawberry. Right? Bhuki, gynecologist ka description. Trichomonas vaginalis lead to multiple punctate hemorrhagic spots which are called as strawberry vagina. So doctor, Shanti, Shanti, Shanti. Thank you very much for a wonderful time we all have spent together. Once more, with the same courage, with the same energy, with the same hope, we will fight on the hills, we will fight on the sea, We will fight on the land, but we will win the war. That should be your spirit. Good luck, doctor. Enjoy a great time. And once more, tomorrow we will all catch up. Don't forget to take the test, and at the end of the test to decide 10 topics, and tonight only you should finish those 10 topics. That should be the goal. So thank you very much, and we will all see you tomorrow. Good night.